The next candidate, please.
Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
I'm good, alhamdulillah, sir.
Okay, can you ask for control?
Sir, I have asked.
Okay. Patient presented with acute abdominal pain and some distension, middle-aged female.
Okay, I'm presented with axial CT scan of chest and abdomen in a patient who present with acute abdominal pain and distension. I can see bilateral pleural effusions. As I scroll down, I can see ascites. I can see some enhancement of the peritoneum over the margins of the liver. Pancreas is unremarkable. Gallbladder is normal. The kidneys are normally enhancing. Scroll down till the last cut. Okay. I can see that in the pelvis.
You reached
I
the
can
last cut?
see. No, sir. As
Okay,
I
very
scroll
important.
down.
I know, but very important in the
Hmm,
exam. Even the last cut, if normal,
hmm,
you have to go
okay.
to the last cut. It's important in the exam because sometimes
Yes, sir.
in a female pelvis, you may find vaginal wall cyst, and this may represent the main complaint in acute patient, for example. So you have to look
Good.
at the last cut. Okay, what do you see here?
So I see bilateral adnexal masses, multiloculated cystic with enhancing septa
Good.
and solid enhancing components which are abutting each other in the midline. As I scroll down, I can see the uterus is mildly bulky
Okay.
and there is pelvic ascites.
Any additional
I'd
history you want to
like to ask if the patient has amenorrhea and if the patient has taken any ovulation induction.
excellent. Let's see the history.
Mm.
Let's see the history. Ovarian stimulation treatment 2 weeks ago. Excellent, excellent, my friend. So what is your suspicion now?
So, keeping in view the history of ovulation induction and bilateral hemorrhagic
Are you
follicles
sure it's a
in the
hemorrhagic?
ovary. No, the bilateral large follicle, ovarian enlargement with
Good,
follicles, ascites and pleural effusion. This is ovarian hyperstimulation syndrome.
very
And
good.
I would inform my finding to the referring clinician and advise urgent gynecological referral for this patient for the management of ovarian hyperstimulation syndrome.
Okay. I'll give you another case of the same category. You can scroll also acute pelvic pain,
So I'm
middle-aged
presented
female.
with
Hmm.
axial images of ultrasound in a middle-aged female who are presented with acute pain. The images are jumping. I can see massively
Sorry, my
enlarged
internet today is not
ovaries.
good. Okay.
Yeah. The ovaries have
Hmm.
multiple and large follicles, some of which are showing fluid level
Yes,
and
yes,
a
yes.
hemorrhagic component
Yes,
and then stroma. In my routine practice, I would see the flow within the ovaries, and there is flow present within the central stroma.
good.
Um, Again, I
Okay.
can see
Again,
ascites. So these
so
are
we have
hyperstimulated
ascites, but
ovaries with multiple
excellent.
hemorrhagic follicles.
Okay. Actually, the same patient
Mm.
did a CT.
Okay,
You can
can
scroll.
I scroll?
Yes.
Okay, it's not scrolling. 1 minute.
Go
Okay, I'm
down, go down
scrolling down.
directly.
Yes,
Okay,
there is ascites, pleural effusion. As I go down in the pelvis, I can see massively enlarged ovaries.
good.
Excuse me for the jumping, please.
No, no problem. It's my
Uh,
internet. It's
mm,
okay.
which also show fluid level,
Yes, yes. This is
hyper-dependent
very important.
densities.
Yes, yes.
Yes.
You see all
Mm,
friends. I will adjust
mm,
the yes. Can I take the mouse? Okay.
yes, sir. Mm,
Even in the arterial phase, you still see fluid levels. In the venous, fluid levels.
mm.
So it's hugely enlarged, both ovaries touching each other, containing multiple large cysts, and many of them hemorrhagic in nature. Okay, with ascites and effusion, again, the most common diagnosis is ovarian
Ovarian
hyperstimulation syndrome. Can
hyperstimulation.
you grade this case? Any grading system?
Sir, I'm not aware of the grading system.
No problem, no problem. It's okay. It's okay.
Mm.
Let's revise together the grading system of ovarian hyperstimulation syndrome. We can grade it as a mild, moderate, severe, okay, or grade 1 according to clinical abdominal distension and ovarian enlargement. Grade 2, ovarian enlargement, abdominal distension with other symptoms, vomiting, diarrhea, and so on. It's about fluid shift. The main abnormality in ovarian hyperestimation, fluid shift from the circulation inside the ovaries and inside the coelomic membranes. Grade 3, development of ascites. Grade 4, development of effusion. Grade 5, due to significant fluid shift, the patient will go in shock and renal failure even. So it's an emergency case, need adjustment of the electrolyte imbalance, and of course, hospitalization. Very good, my friend. Differential diagnosis of bilateral enlarged ovaries.
Sir, it can be mucinous cystadenomas or adenocarcinomas. It can be also in acute setting, it can be torsion, any cystic
But
ovarian
bilateral,
mass.
unlikely, but it's accepted. And also, it can be fecal lutein cyst of
Choriocarcinoma, gestational trophoblastic disease
as
of
so.
pregnancy.
It's important to take history about ovulation,
Mm.
induction, stimulation, and also beta HCG. Okay, if shooting number of beta HCG, oh, we have to do ultrasound for the uterus, and we have to do biopsy. Okay, it may be molar changes. And if a pregnant lady with twins, it can show also bilateral enlarged ovaries. Very good, my friend. The last one. No, hemorrhage is a common occurrence here. Okay, it's a very common association. When rapid enlargement occur, hemorrhage occur. It's highly suggestive sign actually. Now, an important case also. You can scroll between images. This patient has acute abdominal pain following ovarian stimulation. What happened?
So I'm presented with the ultrasound images of right ovary in which I can see multiple and large follicles, and I can see the ovarian stroma is hypoechoic at the periphery. It is dense centrally, but towards the lateral side it is hypoechoic. I wonder if it is any hemorrhagic cyst filled with hemorrhage, or it is the hypoechoic stroma. I would like to see other images.
Okay,
Sir,
I'll give you also.
yes, please. This is the left ovary, which is normal in size and showing normal blood flow. So I
Usually
would
it's
like
enlarged also, يعني, but
mildly,
you
mildly
see,
large, 7
you,
into 5
yes,
centimeter.
yes, you said
Mm.
it's normal because you compare it with the right side. No, ovarian
Mm.
hyperstimulation, usually both will be enlarged. But the main abnormality here
Asymmetrical.
is,
Sir, can I see the first image, the right ovary again?
yes, okay, I'll give you
So
side by side. Okay, Doppler.
here I cannot see any flow within the right ovary.
This is number one.
So,
Good,
and it is more enlarged
good.
as
Number
compared to
two,
the left with
and
hypoechoic
edema
periphery.
around each
With,
follicle. You see imperceptible wall here. This is normal. But here, edematous
Mhm.
wall against
Mhm.
of each enlarged follicle. So we have multiple signs. Pain is not enough because ovarian hyperstimulation may be associated with pain. What is the diagnosis here, my friend?
This is a likely ovarian ischemia due to multiple ovarian congestion and venous infarction, possibly due to
Mm,
multiple
ovarian ischemia. You
multiple
can say
another.
ovarian torsion. 20% of these cases are prone to torsion. 20% of ovarian hyperstimulation are prone to torsion. The most sensitive sign is vascularity. You see here, very low peak systolic velocity. It's very important to lower the velocity. And in ovarian hyperstimulation, it's expected to show hypervascularity, enlargement and hypervascularity. So not just ischemia, it's ovarian torsion. And this is an emergency. It may occur without pregnancy or it may occur after pregnancy occurred. Okay? Yes, the previous case, Krokenberg, may be a differential, but very good, usually solid, not cystic. Okay, my friends, so this is a case of ovarian torsion on top of ovarian hyperstimulation. Thank you, my friend. Well done. Well done.
Thank you, sir.
Okay. Till now, we are in the category of pelvic pain. The next candidate. I cannot hear you. No, the voice is very muffled.
Sorry.
Yes, yes. This
Is
better?
this better?
Yes, yes, yes.
Okay.
Very good, very good. How are you, my friend?
I'm good. How are you?
Alhamdulillah. Can you ask for
Alhamdulillah.
control?
Okay, one moment.
Take your time.
How can I ask for control? I'm sorry.
Okay, I'll give you. No problem. You are 36, okay?
Yeah.
You have the control
Yes.
now.
Good.
Acute pelvic pain, middle-aged female.
I'll take a minute to go through the images. I can see there is ascites. The liver looks okay, and the spleen looks okay.
Okay, I'm presented with a CT scan of the abdomen.
Oh, yeah.
Okay, okay.
Sorry.
Don't
Okay.
forget.
Yes.
Okay.
Okay. I'm presented with the axial cuts of the CT of the abdomen with portovenous contrast.
Good. In a patient complaining of pelvic pain, some examiners will tell you, please do not repeat the complaint. Okay, no problem.
Okay.
Okay.
With acute pelvic pain. Okay.
I'm scrolling from the first cut till the last cut. You have to continue talking. In
Okay.
the exam, you have to continue to don't avoid long stop. It will be negative and it will give you a minus in the communication marks. Okay.
Okay. Okay. Reach now to the pelvis, and I can see large amount of pelvic collection of high density, and on the right side, you can see some contrast extravasation here.
Good. Very
But there
good.
might be some hemorrhage, element of active hemorrhage here.
Good.
I want to ask patient positive beta HCG.
Very good. It's negative.
Not
Good.
negative. Okay. So this excludes interrupted pregnancy.
Disturbed ectopic unlikely in this
Yeah,
setting. Very good.
pregnancy. Yeah.
So what is the remaining possibility?
Has he got any history of fever or
Good
any
again, but
constitutional symptoms?
no fever or constitutional symptoms. Just pain.
Okay.
You have this area of extravasation and some fluid in the cul-de-sac.
Some fluid.
Yes, filling of
Yes.
the cul-de-sac posterior to the uterus. What is your
Yeah.
suspicion and what to do next to confirm?
I not
Your
know.
internet is like mine. Okay.
I think so.
Diagnosis?
Mm. I'm not sure, to be honest.
Okay, no problem. What
What's
is
the
the
diagnosis?
differential diagnosis of ectopic? You suspected ectopic, but we excluded it by laboratory. What is the differential diagnosis of ectopic?
Tubo-ovarian complex or But this also, the patient doesn't have any
No fever,
constitutional
no
symptoms.
constitutional, just pain
Yeah.
and extravasation. It's hemorrhage. It's
Yes.
adnexal hematoma. Okay?
Okay.
Pelvic
Okay.
hematoma. Pelvic hematoma
Yes.
may result from ectopic or rupture ovarian cyst. Okay?
Okay.
So in my
Okay.
routine practice, I will ask about complementary ultrasound, for
Previous.
example, okay, or previous studies. Okay.
Previous studies. Okay.
I'll give you ultrasound. I'll give you ultrasound. Just a
Okay.
minute. Okay. Give me the mouse, please. Okay, leave the mouse. Leave the mouse. Leave
Okay.
the
I'm
mouse.
leaving it. Thank you.
Okay. Okay. I will scroll for you. Okay.
Okay.
This is the right adnexa by abdominal
Yeah.
ultrasound. Okay.
Yeah. Okay. So it's abdominal. Okay.
And
So
this uterus, I
Mhm.
see some heterogeneity around the uterus. It's periuterine hematoma. This is the area of hematoma seen on a CT scan. Actually, it's not well defined. Abdominal ultrasound is not accurate. I'll ask if the patient is married to do a complementary vaginal ultrasound. But we see something in the right adnexa. It's heterogeneous, mass-like. Is most likely adnexal hematoma. Even if we see a vascularity inside, no problem. It's maybe an ovary surrounded by hematoma. And we have to comment on the other ovary, which is normal. Left ovary, normal texture, normal size, but we have some hematoma around. We did a complementary vaginal ultrasound. Uterus is normal, empty, doesn't contain any decidualization or sac or whatever. And we have heterogeneity around. On the left adnexa, normal ovary or some PCO appearance. And on the right side, let's see, it's a hematoma. Heterogeneous structure surrounding the testis, the ovary, which is represent ruptured ovarian cyst or disturbed ectopic, according to beta subunit. So this is most likely ruptured ovarian cyst. It's very, very, very common in practice. Very common in practice. My specialty is ultrasound and Doppler, so I saw it every week. Every week. Okay, disturbed ectopic and hemorrhagic ovarian cyst. Main differential. Okay, you see, normal adnexal hematoma. Again, on a CT scan. In my routine practice, I will comment on this on the pre-contrast study. Why? I will look for any hyperdensity, which represent hemorrhage. You see, oh, this area is definitely abnormal, and as you mentioned, it's right-sided areas of extravasation, and this is the normal leftover. Okay, so it's gynecological emergency. Another patient, same complaint. Okay, acute pelvic pain, middle age. You can scroll.
I don't have the control yet.
You have it. Okay.
Yeah, I think I do now.
Okay.
I'm presented with the axial CT with I don't think this is a contrast study. It doesn't have any contrast. The patient is complaining of acute pelvic pain. You can see very hepatic and very splenic collection.
Good.
Kidneys appear normal. The loops not distended. You can see here, cystic here and here as well, with rounding high density fluid collection.
Usually in the acute pelvic pain, we do a contrast. What is the value of a non-contrast study?
To check if it's hyper, and with the post contrast, it's hyper.
Yes, to check the density.
Pre-contrast,
Yes.
And then with the post-contrast, if there is any new hyperdensities
very good.
with the
What do you think about this area? Right, paracolic gutter. Any hyperdensity? Or clear fluid? Right, paracolic gutter. Here.
I can see. Oh, okay. So I can see some areas of fluid collection, but they do not appear like a simple fluid. It appears more hyperdense.
See the right paracolic gutter? We have a dependent hyperdensity. Dependent
yes.
hyperdensity.
There,
It
there
means
is
a hemorrhage.
hyperdensity.
And also
Yes,
around these follicles, anterior,
yes,
beneath the
yes,
abdominal wall, another hyperdensity. So we're
yes, I agree.
suspecting pelvic hemorrhage.
Hemorrhage.
It's called
Yeah.
hematocrit value or hematocrit level. I'll give you a contrast from up downward. What do you see?
So, you can see multiple linear, maybe vascular scrolling. My
Hello?
mouse is not scrolling. Hello?
No problem, no problem. Even if not chronic. You see here
Yep.
in the right
Yeah.
adnexa two cystic structures.
Yes, I can see two
Oh,
cystic structures, and the lateral one, it's surrounded by hyperdensity, post contrast externalization
yes, very good.
from the adjacent iliac arteries.
Good.
Not scrolling, I'm sorry.
No problem. Ignore this. I can scroll for you.
Yes, scrolling now.
Okay. It's okay. It's okay. I'm scrolling.
Yeah,
But
okay,
it's
thank
okay.
you.
So we have abnormality situated in the right adnexa. I know I don't see the
Yeah,
uterus well. I don't see the left adnexa well,
mm,
but definitely we have some hemorrhage in the cul-de-sac,
hemorrhoids.
and we have hematocrit level at the right paracolic gutter. So we suspected
Mhm.
a right adnexal lesion.
That's hemorrhoids.
This
Okay.
one may represent what, and this one may represent what?
These are cysts as well.
This may represent just a normal corpus luteum or ovarian cyst, and this one
Yeah.
extra ovarian structure. Like what?
Mm, like a mesenteric cyst or something, but it doesn't
Middle-aged female with pain. You forget to ask about menstrual
Mm,
history. Again,
yes. Yeah.
any
Sorry.
any female, okay?
Yeah. Okay.
Female in reproductive age, ask about menstrual history and request beta
Yeah. Beta
HCG.
H. Yes.
Actually, let's see. Oh,
Okay. So it's 2000. So it's positive.
you see? Yes,
Yeah.
yes.
Yeah.
This is
So
equivalent to sonographic sign named ring of fire.
yeah.
Okay. If
Interrupted
ultrasound,
ectopic.
yes, it's a disturbed ectopic. It's a
Mm.
ruptured
Mhm.
ectopic. And the ectopic
Yeah.
is an extra ovarian. It's a
Mhm.
tubal. So you may see
Okay.
the ovary containing corpus luteum, containing cyst, whatever. And this is extra
Mm.
ovarian in nature. So again, acute pelvic pain in a middle-aged female with adnexal hematoma, adnexal heterogeneity. This hyperdensity best seen in the pre-contrast study. What is the Hounsfield unit of this blood in pre-contrast? What's expected?
Around 40s or 50s.
Or maybe 60 or 70 even. Okay. Okay, I'll give you just a similar case, acute pelvic pain. We started here. What do you see here?
The right lobe of the liver.
It's normal. This is called
Normal and
hepatorenal pouch or Morrison pouch. It's normal. This
yep.
is the first view in any middle-aged female with pelvic pain. Why? Because minimal fluid accumulate here in the Morrison pouch. So the first view must be hepatorenal pouch or Morrison pouch. We completed the study, abdominal and pelvic, and we see this structure. Okay, you see here the ovary and extra ovarian, okay, cystic lesion with thick wall and hyperechoic wall. It's a tubal. Okay, no claw sign. And when we do a Doppler, we have something like ring of fire. So this case, of course, I will correlate with beta subunit, which is positive, disturbed ectopic pregnancy, or just ectopic. Okay, so acute pelvic pain in a middle-aged female with pelvic hematoma or adnexal hematoma, ask about menstrual history and laboratory beta HCG. The main two differential diagnoses are repeat.
Interrupted ectopic
Yes,
pregnancy
yes,
and hematoma.
and ruptured ovarian cyst.
Ruptured ovarian
Ruptured
cyst. Yeah.
ovarian cyst. Okay, both are gynecological emergencies, likely surgery. Thank you, my friend. Thank you.
Thank you.
If rupture ovarian cyst causing minimal hematoma, I will take the control in the back. Okay. If minimal hematoma and the vital signs are preserved, I think they can do a conservative management. But if significant hematoma or drop of vital signs, definitely it will be surgical. Okay, I will continue. Then I will divide the record later. We have the next candidate.
Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
I'm good, alhamdulillah. Sir, how are you?
الحمد لله رب العالمين. الحمد لله. Can you ask for control?
Yes. Yes.
Now we have another category of cases. Middle-aged female, pain and fever.
Okay. Okay, this I'm provided with the CT scan of the abdomen, axial slices, and a portal venous phase of a female patient who has presented with pain and fever. Okay, I'm trying to scroll.
Yes.
Okay, I can see that there is bilateral mild pleural effusion. And other than that, I can see that there is mild periportal cracking. So there
Okay.
is some lag in the
I will scroll.
flowing.
I will scroll. I will help. No problem.
Okay, I can see that both the kidneys are showing normal post-contrast enhancement.
Okay, this is a variant. Okay.
The malrotated, both kidneys are
Yes.
malrotated. The hymen is oriented
Okay.
anteriorly. Okay, and I can see, other than that, I can see there is a fluid in the paracolic gutter.
It's
And
important to reach the last cut. Very important to reach the last cut. Okay. What do you see here?
So I can see that there are multiple serpiginous vessels adjacent to the uterine cavity on both sides. Along with that, I can see that the both ovaries are have multiple follicles. And there are innumerable enhancing vessels in the region of cervix
Good.
and the periuterine region, along with fluid in the cul-de-sac.
And also,
Uterus.
subtle enhancement of the
Yes.
peritoneal cavity also may be seen.
Yes.
What is your suspicion and what to do next?
Sir, I'm suspecting some pelvic infection or a PID, since there is increased vascularity and
BID
there is
and
fluid.
because if you suspected BID, conservative, medical,
Okay.
but BID
Okay.
and
So there is a fluid in the pelvic cavity. So
what
the
is this? What is this multilocular cystic structures
sir,
that show enhancement? Hmm?
again, sir, this could be abscesses or
Yes, yes, yes,
ovarian
yes.
abscesses,
Yes,
tubo-ovarian
tube ovarian.
abscesses.
Yes, tube ovarian abscess. I think this may be a residual ovary. Maybe CT is insensitive, but I cannot see an ovary here. And usually, in case of tube ovarian abscess, the ovarian stroma underwent necrosis. So
Okay.
it's accepted not to see normal ovary in case of tube ovarian abscess. And of course, gynecological emergency for surgical drainage as well. Another case, my friend, same history.
Okay.
Pelvic pain, fever, discharge.
Okay, so I'm provided with the T1 weighted axial slices.
I will scroll for you or you.
Okay.
I will scroll
Sir,
for you.
please scroll
Okay.
for me. Yes.
Okay, no problem, no problem.
I'm
Sequence
provided
and
with
findings.
T1 weighted. Okay, so this is T1 weighted non-fat cell sequence of a female patient, in which I can see that there is a large collection in the right adnexa with the peripheral thick rim,
Good.
and I can see that it is in the posterior cul-de-sac, and on the left side, I can also see that there is a multiloculated collection and somewhat tubular with thick peripheral
Excellent. So I have a bilateral, and the one on the right side looks tubular. Okay. If no given history, my friend, with this tubular structure, any differential?
So hydrosalpinx,
Good.
hemosalpinx.
Hydrosalpinx, hematosalpinx, biosalpinx. Very good. Okay, I'll give you T2. Oh. What
Okay,
do you
sir.
see?
This
It's
is
not
uh,
hydrosalpinx. Okay,
okay, okay,
it's
sir.
not clear
So this is
float.
okay, sir. This could be, sir, abscess. I would like to confirm my findings on diffusion weighted sequence since I cannot
Okay,
see the right organs and
diffusion,
organoids.
very good. And contrast
The contrast.
study.
Yes, yes,
I'll
yes.
give you contrast. Whoa,
Okay, sir. On contrast, this confirms that there are bilateral ovarian abscesses larger on the right side with thick peripheral enhancement and central large area of necrosis.
very good. Mm.
So this is an emergency and requires drainage and follow-up.
Yes, you see, tubular structure go with dilated or fallopian tube, and also incomplete septi, this rosette pattern or spoke wheel pattern, also incomplete septi. So it's bilateral tubo-ovarian abscess. In such case, I think any no normal ovary will be seen on usual sequences like T2. And again, it's of surgical, gynecological surgical emergency for drainage and antibiotic coverage. Repeated history usually because it's a common cases of BID, unlikely post-operative to represent like this. Okay. Thank you, my friend. Okay, so the second category, we have a fever. So suspecting infection, either BID or post-operative. It's proteinaceous fruit. So abnormal signal, usually on T1, and more important on T2. Very good, yes. In case of abnormal enhancement along the right paracolic gutter, up to, in such cases, it's very important to go to up to the liver and gallbladder fossa for the possibility of perihepatitis. Very good. Or Fitz-Hugh-Cortez syndrome. But usually in Fitz-Hugh-Cortez syndrome or perihepatitis, the abscess will be along the right paracolic gutter or even subhepatic in location. But this is for Bismillah ar-Rahman ar-Rahim, for practice, not for the exam. Perihepatitis is difficult and to be presented in the exam. It's for practice. Yes, we can do image guided drainage. Okay, or surgery according to gynecology.